afternoon, everybody. Thank you for coming. And it's going to be another interesting session, as always. You know, for IMCAS Asia, we always have like 2 hours of complication session collaboration with the Thai custom. And today we have all the panels who are the global expert in injectable and also complications. So please welcome our panelist, Dr. Sonia Sadler from Germany. Eugene Hong Ha from Vietnam. Okay. Dr. Singh Kudi from India. Mauricio, please come. Plastic surgeon from Germany. All right, doing okay. And Dr. Thomas Lavel, are you here yet? Oh, okay. Please come. Please come. Oh, no chair. Please. No, you take my chairs. You take my chairs. Please do. Come. Because I'm going to stand anyway. No. Here. I'm serious. Okay. I need my glasses. Okay. And Dr. Aravi, gynecologist from Mahidol University, Thailand, Bangkok. Please come. We can stand. We are Thai. Okay. So, okay. And our anatomist. Now she becomes very skilled and famous, globally, Dr. Benrita. And then we have another co-chair, Dr. Natasha, who have another lectures in another room, but he will come later. Alrighty, so we start with our session now. Okay. ชื่ออะไรได้ไหมคะชื่ออะไรได้ไหมคะปรับสไลด์ให้หน่อยได้ไหมคะ
ชื่อเบลลิตานะคะวันนี้ไม่ใช่นะคะ
ใช่ค่ะเป็นอันเดียว
อันเดียวกันค่ะ
ใช้อันเดียวกันหมด
อันนี้ใช่ค่ะถูกต้องค่ะ
Last year we have like all scaly complication, but this year gonna be a little bit more soft, but more I think is more common. Okay, and I hope that we can learn a lot from our expert today. So we start with the case of Udip. Can you help us telling about your case?
Yeah. Okay, sorry. I can keep it.
You don't need that. We need that. Okay.
Yes. Okay. So I think we can use this. Yeah, better. So we start with non-vascular complications, and I don't know how often you see it here, but we seem
We
to
see quite often. Yes.
quite a lot,
Yes.
and a lot of infections. And so we'll start with the first series of cases, the abscesses or inflammatory nodules, or more significantly, atypical mycobacteria. And many times these will present as erythematous areas or erythema, edema, and tenderness altogether. And this comes within like 3 to 14 days, sometimes from 1 week to several years after treatment. And we are wondering, it is just infection. And what is suggested, and this was by all the references mainly by Font and Pavicic, to incise with a 11-number knife and send the pus for testing. Many of us don't. And empirically, waiting for that, we would start with drugs which would cover atypical mycobacterium and MRSA both, which usually was supposed to be a combination of a macrolide and a quinolone, or sometimes a tetracycline. So if there is HA filler, then you can in addition use Hyalase to dissolve the nidus. But you have situations where there is no HA filler, and then you are wondering what to do. So this is a patient, and he had toxin injected about 2 weeks ago before he came to me, and the nodules were noticed 1 week after the injection. So if you see on the left side, this one, and on both sides, all the points injected became like this, and he and his wife actually both were injected, both developed. And they were injected with separate syringes, separate vials, separately diluted, but both developed this. And they were treated with steroids initially, and they disappeared. The moment they stopped steroids, they came back. And any ideas?
How would you differentiate between whether this one is from infection or immunologic reaction? I mean, before we knowing pathology or we knowing the...
Okay. Well, this has been, which filler has it been?
No, this was toxin.
Toxin.
Yes.
Okay, a toxin. Oh, if it's a toxin, yeah, I think here's the ultrasound god, so I think he would put the ultrasound on. But probably if this is persistent, I would go for a biopsy, bunch biopsy.
Okay, okay.
Well, it's very unusual for a toxin, super unusual. So it might be either a product related problem or a reconstitution-related problem, because we expect the vial to be sterile, but it's very unusual.
Yeah, surprisingly, the husband and wife both were injected, like I said, with different vials, different syringes, different diluting substance separately. So they did not share a common vial. And so we delved into this, and water has been incriminated as one of the sources for atypical mycobacterium. What we did was an FNAC. And in the FNAC, we found giant cell granulomas, and we couldn't get enough for a culture. I had treated similar patients before, so we started both of them on a combination of a quinolone and a macrolide, and initially steroids, and we tapered the steroids in 2 weeks, and continued this for almost 6 months. And then both of them, the nodules disappeared. And so on the right, so if you see on the right side, this is all gone. They're still my patients, and he brought to me, the patient is a lawyer, and he brought a reference for me that this was technique induced, and I gave him a reference which showed water as a source, and so that could calm them, and we treated, and I'll come to the remaining ones before we decide what precautions you should take. You want to say something?
No, it's okay. Yes.
Another patient on the left is the before treatment dorsum of hands, and she was treated by filler and HA filler, and she was fine till about 2.5 months when she developed swelling and redness. And so again, this was quite some time later, and she came to me. Actually, she came to me after 2.5 months, but I think after 2 weeks she developed this, went to somebody. People didn't know what to do. They thought it is allergic response or delayed hypersensitivity, but so they gave her steroids, and again the same thing. Somebody gave Augmentin, and with steroids again it reduced in severity, but it came back. So here, since it was HA, what we did was we started again on quinolone and macrolide, and after 2 weeks of cover, we high-laced the dorsum of hand completely. And on the right, you can see this after 3 weeks of high-lacing. The treatment continued for another 3 months. I don't have the late pictures of this patient. So again, sorry.
I'd like to raise a question whether when we see cases like this, how would you do it? Will you start antibiotic first and then do high-lace, or how would you manage your patients if you see patients like this? Anyone?
I think that as a beginner, when I receive the case like that, I need to make sure that what is the diagnosis. Because when you're talking about the infection, so you need to try to see what kind of the bacteria. Is the Mycobacterium is totally different with other like Staphylococcus. So try to, can you tell me that, what kind of infection, or it's sure that it's infection, or it's just not only inflammatory. And the second thing that we would like to know also about what kind of filler, because for the hand, rarely we do only the filler. We do the KAHA, we do the other thing, the PLNA. So the different thing have a different treatment. Yeah.
So, yeah.
I'm really sure that some people here are now using ultrasound, and that's a very important tool in order to have a look below the skin and not be guessing what's going on. You can analyze if there is inflammation going on, how the vascularity is, how the echogenicity of that nodule, or that thing that is below the skin looks like. After that, and if you are skilled or you have experience with that, you can tailor the treatment, whether it's first treating antibiotics, or even having a look if you need more diagnostics, like PCR, when you want to diagnose atypical mycobacteria. And it is a little bit different from country to country. In Germany, where I live, for example, ciprofloxacin is a reserve antibiotic, so you would not give that at the first line because of the side effects. So we tend to start with something like doxycycline, a macrolide. And yes, if you see fluid collections, make a drainage, take it out. So having a tool to have a look below the skin, it's very, very helpful.
Yeah. So two things. One, if you have material which you can aspirate or drain, and then you can do a culture, a stain, RT-PCR, then it is okay. But these two cases, we did not have enough material. First one, we at least got a drop of fluid. No material we could get for, and this is quite some time back. This is almost more than 10 years ago, this patient. And we were still, learning. I'll show you once where we did everything. And ultrasound showed only swelling, edema.
Yeah, but you can also see where the material has been applied. We know that injecting the hands, it's a matter of not even millimeters, and then you land very easy in the fascia. And we know that in the fascia, we have perforators. When we compromise even also the venous outflow, you might have also swelling.
So this is subcutaneously placed. I know the injector, and she told me this is subcutaneously placed with cannula, very low G prime filler, and this happened delayed, and it always temporarily responded to steroid, because initially they thought it is an allergic response, and blood reports did not show any significant change. So all of these, as we go ahead, we'll see that many of them they've tried, and they've tried mostly comoxiclav. We don't give tetracyclines in our practice so easily, because quinolones are much more freely available. Again, I think it differs from country to country. I'll just go to the next patient. Yeah. So this was a patient who had threads inserted in her face, and under the chin she had some lipolytic agent injected. So two different things in the same face. Again, all of them developed abscesses. And here we could get enough material, we could do RT-PCR, they grew on culture, we could get a sensitivity. So everything was possible, and since there was no material put here except under the chin when they put, again we couldn't get any material there, but here, if you see, so the culture grew atypical mycobacterium, and it was sensitive to both these drugs. And we kept draining, because the pus would keep forming for some time till, but the important thing was that we just used a stab knife drainage to just release, and not like many surgeons would do big incisions and leave scars. And again, it took almost 6 months for her to settle down. Now, again, two different procedures done. What possibly could be the cause? Fat dissolving thing here, threads in the face, all infected. So what possibly could be the cause?
I think in all the cases where some foreign material has been inserted, it has to be taken out, like in this case, so fishing the threads and bringing it out. Probably this is adjunctant to this infection of the threads that there's also, it's not from the lipolytic, so it's also possibly also the infection which is coming up from the threads, from the infected thread. So I would take it out as far as possible.
Yeah, they were
Easy to
simple plain threads. They were not even cog threads. And they were simple threads. And by the time she came to me, it was almost a month. Again, routine antibiotics given orally, no response. So, but we could drain each of them, get pus, send material. RT-PCR was positive. Atypical mycobacterium grown in culture. We unfortunately couldn't get a subculture to get sensitivities, but she responded well to, like tuberculosis, where you keep draining the nodes till they start drying up. We did that, and fortunately for us, she healed without any visible scars. She is still my patient. I mean, I treated her. Now the problem, again, there's another problem. If somebody's had such an infection, when would you think it would be okay to do aesthetic procedures in this patient? Because she came to me, she said, I want fillers, I want toxin, I want threads.
Do you mean in the same area or different area?
Her face, the whole face. So you can't get away from that.
But she have any risk to get easily the infection with Mycobacteria?
No.
Because she can have a diabetic something that is like the favorite factor to get infection easier than other people. In this case, I think that you cannot do.
No, she is a young, healthy woman, and nothing, absolutely no predisposing factor, nothing. She is still my patient. Now it is more than 10 years, and she is still my patient. But this was a problem, she said. So when is the earliest we would recommend starting an aesthetic procedure? Toxin is still okay, you're not putting some material inside, but fillers. So I want to ask one by one, when would you do?
So I would do probably wait at least 6 months, better 1 year, and then start with a filler I really know, a no biostimulator. An
Yeah.
HA filler I'm very sure, which doesn't make any other problems.
I agree with that.
So, but I wonder that for the Mycobacteria, you use only clarithromycin and Cipro, only 2 antibiotics.
Only 2 drugs, yes.
Normally, sometimes we need to combine the 3 or 4 different.
Yeah, we have one patient like that. I'll come to that.
Yeah, but this one is
Yeah.
very lucky. So she is not
Yes.
something very difficult to treatment. It means that with 2 antibiotics, it's still okay.
In fact, Mycobacterium chelonai, you can treat with monotherapy, only clarithromycin. That is one atypical mycobacterium which you can treat with only 1 drug. And then there will be one you can treat with 2, and then there are ones which will not respond to 2 drugs, and you have to add something.
Yeah. So I think that in this situation, if is your patient, it means that she go for you for the first surgery and get a little bit of complication. She's not happy. So I think that's okay. Wait for 6 months, and you need to continue to do something for her to get better. But if it's not your patient, it's the patient of someone else, someone different. So perhaps I maybe say no, or I will choose the procedure without any foreign body. That's cut the skin a little or something. That's because with foreign body, the risk of infection is very high. We don't know what happened with her.
So she was not my patient, but like Dr. Sonia said, waited for 6 months. And the first thing I did was toxin, not filler. I said, let me probe and see, not put any residual material inside, and see how she responds. And then it was a while before we started doing, almost a year before we started doing any fillers.
I think the question is, will we doing HA on her ever?
Why not? If you can
do?
dissolve it, if you can,
Okay.
if you have a reversing agent, in
Okay.
case that something happens, why not?
And why do you have to wait for 6 months then? Any particular reason we have to wait for 6 months before starting any procedure?
I think this is a typical plastic surgery approach. When you have an infected implant, you remove it, you wait for at least 6 months. It's a period of time to be safe, and then with the blood test, you see if everything is clear, and then I think you can go for it.
Okay.
Do we have existing data about that? Like that really define? Is there a difference if we wait 3 months, 2 months, 8 months?
No, 6 months, I think we, like Thomas said, tissues to become soft and supple. They will not respond to your filler administration if they are indurated, if they are hard, if they are not supple. So that is the thing we wait for any surgery, next surgery to do, at least till the tissues become soft and supple. And that is an indication that most of the inflammatory response has subsided. That is what you also go by color, the redness has gone, there is no pigmentation. And so that probably is a safe time to start. Otherwise, you could keep waiting and there is no empirically otherwise any data available.
So, is it possible that we can have some conclusion about the algorithm of how we treat nodule or assess, a patients like this? How would we do it?
Of course, having a thorough anamnesis approach.
Yes, approach.
Then
Because I believe that the audience would like to have like a practical point.
yes. So if you use an ultrasound, of course, I would recommend to use this tool. If you don't, maybe you can ask a colleague that helps you with some imaging in order to identify the problem more close. If you have fluid collection and you aspirate, always be in contact with the laboratory that you are connected with, and always ask for atypical mycobacteria, atypical bacteria, because most of the times the people don't ask for that. So, and at the end of the day, in the cultures, nothing grows, even because patients are taking medication before. In most of the cases, they are already on antibiotics, so you don't see anything growing. So ask for atypical mycobacteria, and always write down that there is still material in situ, so that the microbiologists can approach this more in depth and have a look at that. And once you know, you can treat antibiotically.
I'm just curious, for the ultrasound, will you be able to differentiate between inflammatory infection or non-inflammatory nodules?
Great question.
With the ultrasound.
Great question. Yes, you can.
Yeah?
So you can observe more vascularization around the nodule. You can observe sometimes more edema, but the most reliable sign is the vascularity. You have active and non-active nodules. When they are non-active, you don't see increased blood flow, increased venous outflow, but when it's inflammatory, you see a lot of activity, a lot of blood vessels, a lot of circulation. That's when you know that's really something going on there.
Because we have another case that we will show you.
Okay.
Okay.
So, going by the history of atypical mycobacteria, and it is quite old, and the first reported was Mycobacterium abscessus from New York. Again, that was some illegal filler used. They still did not know what caused it, had partial response with Clarabid, and they added prednisone and tapered it. Rodriguez et al., again, he reported 3 cases of Mycobacterium chelonae, and after filler injection. But most important was that he isolated the atypical mycobacterium from water, tap water. And there was also a study from Melbourne. After fractional CO2, 2 patients got abscesses in all the areas, and they diagnosed that as atypical mycobacteria. And then the health authorities went to the clinic and they tested every possible place, under the sink, in the tap, suction machine. Finally, somewhere the outlet of the suction machine, they found some. But when they typed it for species, it was different from what was grown from the patient. Then they wanted to examine the house of the patients, and they refused. And so it is now quite often, they exist in tap water. And therefore, one of the instructions I give to patients is that day they will not wash their faces with tap water. That is one thing we regularly say. And I've added to my post-procedure instructions. And then initially we would give first-line ATT along with Clarabid and quinolone, but nowadays we don't. Sometimes they don't respond to, we had one patient, he was not a filler patient, but they were sensitive to 4 drugs, did not respond to anything. Then we had to add a MDR like clofazimine and ethionamide before the patient could respond. So resistant cases, it is really difficult. I'll just tell you this 44-year-old female, somebody used this injection, Fatex, in the bra rolls, in the medial thighs, axillary bulges, even in the axillary breast. And 5th day, she developed abscesses. And some general surgeon drained this with big incisions and did not send any culture. If you see, this is what she looked like initially everywhere. And this is what the general surgeon did. Right? So then she came and initial culture grew pseudomonas, but then they gave the sensitive antibiotic, nothing happened, no response. Pus kept on collecting. And then we took pus, we did an RT-PCR, we did a culture, we got positive mycobacterium abscesses in both. And we got a sensitivity which was quite wide, and this time a infection control guy also was collaborating. And I don't know, somehow they tend to use, I thought they would use less antibiotics, they use more. And so we initially put her on clarithromycin and levofloxacin, but she developed a rash, she developed joint pains, and we thought she is allergic to quinolones. So minocycline was also a drug to which the bugs were sensitive. We added minocycline. Then she had dental problems. She has perforation through the entire crown, and so finally stopped that. And then linezolid was added, which was again sensitive. And if you see her, this is they used a line probe, and they used a molecular method based upon hybridization. So detection methods will make a difference, otherwise all cultures will keep turning negative and you will get nothing. And this is now, and she's almost healed 2-3 places where there is crust. And so again, you cannot think of either you say the product was contaminated, the syringe was contaminated, still you would not get it at all places. In all the patients you saw, every possible injection point got contaminated. And therefore, there was a common factor which all the injection points were exposed to. And I don't know, we have not, in this also, we have not been able to find a cause other than tap water. They all washed themselves the evening of the procedure with water. They had a bath and everything, and so that is that.
So normally when we do like injectable, I usually do close the wound with Sura strip and keep it, no tap water for at least 3 days.
Yeah, I think we have to be very careful about this, and in the threads, yes, we close it with steri strips, and then even if we do lasers, like I tell them 3 days, no washing with tap water.
Right. Yes.
And I think most of them are okay with it. Only we never told them.
Yeah. All right.
Thank you.
Thank you so much. Thank you so much. So next will still be in the NODU series from our hospital.
Okay. So let's move on to the NODU series. Please do not take pictures or video from our patients. And the first case is a 41-year-old female patient. She complained about, she had done under-eye filler injection, and on on the temple, nasolabial fold, and immediately after injection, she started to feel swollen of her under eye area and also medial cheek. However, she didn't feel any tenderness, and she has no underlying conditions and not taking any medications. This is the picture of the patient. She said that she feel that her filler on her under eye area is swollen a little bit. However, she has no tenderness upon palpation. However, on the right side of the page of her eye, you can see a little bit more swollen features comparing to her left side. And she also doesn't like about the discoloration under her eye as well. She said that it looks a little bit more bluish comparing to before injection.
The swelling is on and off, or just is
No,
on and off, or is persistent?
The swelling is persistent after injection. Yeah, she said that there is no intermittent swelling, there is no off and on swelling, just only persist after injection, and gradually even more swelling after injection. So at our hospital, we have ultrasound in our practice. So what we did is we did ultrasound for her, and you can see that there are multiple anechoic deposits on her under eye area. And however, you can see that there's some pockets of material going up to upper part of her superficial fat here, and also most of the HA is on the lower part here, and there's some scatter to the cheek area as well. So what we did is we also did a flow, and we found that the filler on her under eye area actually partially obstruct the flow, but unfortunately we unable to retrieve the video. But the flow is quite impaired also. So what we did is we did ultrasound guided injection hyaluronic dissolution to the affected area, like this. You can see that this is under eye and also the upper medial cheek area. We deliver hyaluronic by using ultrasound guide in plane technique precisely into the pocket of HA here. Okay, another angle. And what we see is that we can see that the flow of vein and artery is getting more pronounced. But actually, immediately after injection, the flow is usually tend to be more. But you can see that the venous flow that is quite obstruct before injection is getting more like open channels after injection. And we follow up the patient for 1 month, and you can see that the swelling of under her eye area is getting better.
Do you have any comment, Mauricio?
This is a great case because when we inject the under eye areas and you are doing it in a conventional way, you sometimes end up first in the muscle, second you might end up also post-septal. There was actually post-septal filler, so below the septum, which is actually also not so, that dissolving is actually very, very difficult. So when you inject there, it's such a good help just to have reassurance where your cannula is positioned. And once you know where it is, then you can inject. And before you inject, you can also assess if the patient has had treatments before, because one of the reasons that cause malar edema is overcollection around foramina. So in the infraorbital foramen, we have a big vein that drains also. And if you have a lot of material compressing and disturbing the venous outflow, that's when your patient is going to have edema, pressure. When she or he goes to the sauna or making sports, make the problem more notorious. So that's actually a very, very challenging case that you are showing how to make the dissolving very, very good.
Yeah, I think it's very important that you know your product first, because
For sure,
the products are really reacting completely differently in this area. Then you know your technique, very precise. There's a little space only where you can place it. And I love to do actually a two-step approach, because I hate to use Harleys in this area, then they have a full tear trough back again. So I tell them we need 2 dates, 2 treatment dates, and I try with very little product, and then I see how the patient reacts on this little amount, micro droplets, not too much, never fill it up in one session, and then they come back after 4 to 6 weeks, and then I see how the reaction has been, and then I can add more product, and then I know more or less if I add much or just very little or none.
Yeah.
That's my approach.
Yeah. So, if you put, so the problem which is caused here is mostly by the superficially placed filler. But yet we are trying to dissolve in the deeper plane. Why it has been effective? Because we injected 1500 units. So now the problem, like Sonia said, you have to do the whole thing again, and it mostly dissolves even the cheek filler. So what I would do, once you've done the ultrasound, you've seen where it is, I would first try to dissolve, like you said, the superficial part. And you can very accurately dissolve. Maybe I tell them it will be multiple times.
Yeah,
and
that's right.
patient does not want all the filler to go away.
Yeah.
And once that is done, then possibly I will, go ahead with the rest of the filler.
So what is your delusion when you do high-less?
Pardon?
What's your delusion? High-less delusion.
Dilution, yes. So normally when I want to do less, I dissolve 1500 units in 10 ml of saline, 10 ml of saline,
10
which is
ml.
150 units per ml, and in the tuberculin syringe, so 150, that is, 15 per 0.1, and each division is 3 units. So I am very accurate with that. Only when it is a vascular complication, I dissolve much less, but otherwise I do it. So you don't end up dissolving most of the filler.
Sonia, will you use the same dilution?
First I would try not to need it at all, but yes, I use the same dilution. I use 150 per 1 ml.
Okay.
Yeah.
Yeah.
I think it's important to tell the audience who is starting with filler treatments not to go to the infraorbital area,
Prevention,
because this is an area which most of the cases are tremendous annoying if they're coming into the office, and it's easy to step into problems. Even for us as experienced practitioners, it might be something where we create complications, and they're almost a little bit difficult to solve. And what else is it's about the technique, what you should learn. Go to the anatomy to see where you treat, and also especially take the right filler for the right place, because we almost see the wrong filler in these areas, which cause problems. And the next thing is when we dissolve the filler, and I agree, so the people are like disappointed when the swelling goes away, then they get this wrinkling.
Yeah.
So you have to take the patient by the hand, say,
Right.
okay, it takes some time, it will take up to 2 to 3 weeks, but then the wrinkling will improve. So don't be
Is this
disappointed. Yes. Well, don't be disappointed, because the wrinkles have not been here before the injection. The injections mostly is because of the tear trough, and then it blows up, then of course it's overfilled, and then you reduce it, and they get the wrinkles. If you wait several weeks, then it will be fine, but you have to take care about the patients and to guide them by the hand.
Well, so speaking of that, do you have any, can you share your technique? How do we inject the tear trough with the least amount of product possible? And then correct. Please share. Yes, we have somebody want to share.
Yes,
Please.
Dr. Cartier, I have a question. You have a ratio between the volume you have to dissolve and the quantity of Yalas you need. You said 150, but when you have to dissolve 3 millimeters of HA is enough. Maybe you have to add some for Malapad, because sometimes you have to dissolve also mid-face, because it's not so close. It's close from the tear troughs, so I believe that sometimes you need much more Yalas. Do you have any problem to put 500 unit or not, or maybe 1,000 unit? How you say ratio? Because sometimes we are little disappointed. Even we use echo guidelines to be sure that can dissolve, but maybe the ratio. I totally agree with you that It depends which product you have. Some products dissolve very easily, but sometimes you need to repeat or maybe to put much more Yalas to dissolve. Yes or no?
Well, that's a good point. Thank you.
There's no limit for highlights.
There's no limit for highlights for me
What,
too.
what I have learned about this is that when you dissolve the under eye, you first tell your patient that it's going to be probably a multi-step approach because you want to be careful. Second, you want to use as less units of hyaluronidase as you want because it can cause much more other damages or dissolve even much more filler around. So, and this is where the dilution of the hyaluronidase is important. If you dilute it too much or you give it concentrated, and you also have to know with what kind of hyaluronidase you are working with, right? Because we have 1,000 different hyaluronidases depending on where you are working. So the Germans, the Thai hyaluronidases, they work a little bit different and they have different kind of reconstitution recommendations. So you have to keep that in mind. And when I use in the under eye, I never use more than maybe 15, 20 units and dilute it, as Sonia said, in 1 ml, 150 units of hyaluronidase. So that's what we have available in our country. And then see how it works, how it goes, because sometimes really even if you use 3 units, it dissolves a lot.
Right. So this is all the good points, and I agree with you, and I do the same thing. With this dilution, we're using the one from Korea.
Liparaz you have here, right? Liparaz.
Yeah, yes, Liparaz, yes. I use that one and doing the same thing with the 1 cc, take to 0.1, and then put saline more to 1 cc, and then use a little on the tear trough. That's a good point. Thank you so much. But I also want to reach, when we want to prevent that to happen, and we're talking about the layer of injection that you mentioned, but I think also the technique of assessment of the patients is really important, so we don't put like too much of the products. So would you please share, Thomas?
So I'm still a fan of the approach with the cannula to the infraorbital area, and trying to get vertically, not horizontally. And now I see the venous compression that impairs the venous outflow, but I think it's almost also the lymphatic drainage, and probably if you're going from lateral and you're making with a cannula multiple passes, you almost make an impairment of the lymphatic drainage, so you have the one thing and the other thing, which is even worse than. So principally, the lymphatic drainage goes vertically. That's why I'm approaching also from a little bit laterally of the mid-pupillar line and going vertically to the infraorbital SUF area and trying not to get over the septum.
Okay, what is your entry point?
The entry point is if you draw a mid-pupillar line, you stay like 0.5 centimeter laterally and 2 centimeters below the orbital rim, because midline of the, if you go medial from the mid-pupillar line, then you have the facial vein becomes up and you have the infraorbital bundle. And medial from the midline, you're in danger. Lateral from this, you're safer. You're never 100% safe, but you're safer.
Okay, so I agree with you completely for the medial part. I would do the same, but I disagree with the lateral part, because I think also from this point you disrupt a lot of fibers when you use the cannula. So I'm using a needle. I'm a needle person, I was raised with a needle. So I'm using a needle really on the periost, and while the needle is there, I lift up all tissue around my needle with the other hand and give a micro droplet. I know the Asians do not have not many problems laterally, but us Caucasians, we have a huge problem laterally. And we do not want to add something to festooning, what we also have in the aging process. So I think a little micro droplet vertically on the orbital rim, laterally to the mid-pupillar line is okay, but not medially. So I think I can be more precise with this little micro droplets. At least that's my technique.
So now we have two techniques.
I just add, that's absolutely true. So for the medial part, I do the cannula, but for the lateral part, if there's still left like a little bit tiny impression, I go in the lateral directly with the needle, but just here, little tiny bolus.
Yes.
I think we are missing the main point here. The main point is the volume you inject. And there's a paper by Belluvari, and they found that this is such a porous, meshy muscle. If you increase volume, it is going to come out. And therefore, we should have a limit on the amount of volume you can put beneath the muscle. There is not infinite amount of space. I know people who put 2 mLs, 3 mLs in the under eye area. So the volume you put will decide whether it will not come then, but slowly with the muscle contraction, it will come out and it will come superficial.
Yeah.
So that's why I do 2 sessions. And in the first session, I never do more than 0.4 per side, no matter how it looks like, how severe the case is. 0.4 is a lot already.
Mauricio.
The point here is that the most frequent complication that I see on my practice is the malar edema and nodules in that area due to injection. And here the thing is that we are not looking for the good candidate for this treatment. So it starts with the assessment. You ask the patient if they wake up puffy or not, if they tend to retain liquids in the face. If they say yes, don't inject that patient because this is going to cause complications. There are patients also with pre-existing malar edema. And if you inject HA, some people do it in order to to make it better, sometimes because you have a line, to camouflage it, you're going to make it worse. So you need to know which patient is suitable for that treatment. Skin laxity, all of that. Everything around skin laxity. So you do the pinching test, you can assess how long these wrinkles stay. If they stay longer than 2 seconds, 3 seconds, you don't do that injection because everything that draws water in the tissue in their under eye is going to probably cause a problem. So the assessment is so important in these things. And also seasonal allergies, patients with heart disease or renal diseases with water accumulation is also a problem.
Mauricio, I totally agree, but I have one more thing. Most of these patients are kind of addicted to treating their under eye area. And even if it's done correctly and it's very nicely smoothed out, they come back and want more. So I think these are very hard to guide patients because they're psychologically focused on this area completely.
Give them polynucleotide.
True, they keep coming for the same problem again and again. I have a patient who gets filler done elsewhere and every time comes with swelling and says, now you treat.
Exactly, I know these patients.
But when you find somebody that is suitable for that injection, I prefer the approach of first treating the surrounding tissue if there is volume deficiencies, like the midface, then approaching the SUF in a deep plane. I use the 23 gauge cannula, something between the 25 and 22, so 23 gauge cannula. I inject first the SUF, and if I dare to inject the tear trough really deep on bone, very small volume, and really using something that is forgivable, not something that is kind of a very extreme G prime filler that is also difficult to dissolve.
So I think it's one more thing. I never do a thread with a cannula there. I do only a droplet. Micro droplets. I think then it doesn't show like a edema in a line.
That's all the very good points. So I like to share my technique before we move to the mala edema problem, because I know it's very difficult to treat when the patient already have it. My technique to treat tear trough. So we're looking at the bone resorption. We're looking at the deficit of retaining ligament. So basically what I treat, I'm treating the lateral part with the posterior temporal fossa, my technique injection. And then I reposition the tissue of the mid face. So you have less pathology of tear trough. And then I go from nasolabial fold from here, vertically, just, a little amount, micro droplet, deposit over the medial part of the orbital rim. It's perfectly smooth, very nice. No problem of this lump and this mala edema, and very natural outcome and very tiny amount. You can fix it with maybe like 0.1, maybe 0.1 cc. Yeah, in
So
one
your
side.
approach is from here
Exactly.
upwards, and what about the infraorbital vessels, the nerves, and how do you
just have to
protect those?
sneak it. Sneak it.
You sneak it.
Yes. Sneak it.
What size is your cannula?
22.
22.
So what I do, I inject a kind of lidocaine first, lidocaine with epinephrine, kind of calm everything down, and using like high water as protection. You know, so we go in, we just sneak, floating in the water. Why? Nobody's speaking. This is like
The thing is, so
nobody's
I am
speaking at all.
always very aware of the infraorbital pedicle,
Yeah,
you know,
I
so
know,
that's why
I know.
I identify that with
I know.
ultrasound. I always do this treatment, ultrasound guided, but it's not the normal thing. So, but
See,
it's important.
if you see, I mean, you with your skill can do it, but if you see the infraorbital rim, it is like a promontory, and the vessel is underneath. So when you go from here, you'll hit here, then you have to go here, then you go up.
Exactly.
With your skill, you can do, but
Exactly,
to
right.
beginners, I don't recommend that.
Exactly, right. And with the water, it's really helpful, yes. And the patient doesn't really feel that much. Because the matter is, where do you put the product? At the tip of the cannula. It's not, where you pass.
And if your patient doesn't have the skin quality for that, then pre-treat it first with a laser, polynucleotide, something that preconditions the skin and improves the dermal thickness. And yes, I actually try to avoid to inject the tear trough.
Okay, yeah. That's another good tip. Thank you. Okay, next case.
Okay, now let's move
We
on.
haven't discussed about mala edema. Yes, we go back.
Okay, let's move on to another interesting case. This is a 47-year-old female patient. She palpated a lumps on her jawline after received treatment of calcium hydroxyapatite. She has been injected to bilateral cheeks and jawlines, and around 1.5 months after injection, she started to feel lumps. However, you cannot see a lumps. You have to palpate it, and you can palpate a small, firm lumps under her skin along her jawlines. So I did ultrasound for her, and you can see that there is a hyperechoic material on her superficial dermis and superficial subcutaneous layer, and you can see strong posterior acoustic shadow. That it means that this material is very blocking the ultrasound wave. Okay, this is the material that we see, and there are so many tiny little deposits along her jawlines. Okay, there is no hypervascularization of this nodule. Okay, so what I did excisional biopsy. I removed the nodules and sent for tissue pathology. You can see this is the nodule that I sent for histo, and you can see multiple multinucleated giant cells engulf the CAHA material inside. You can see the CAHA material, lots of it in the specimen. This is the CAHA material, and you can see a giant cell eating the material. So the diagnosis is foreign body granuloma due to calcium hydroxyapatite. And so this is something that we need to talk about today as well, right? Hyperdiluted, yes.
So
Hyper meaning how much? 1 to
Sorry?
2, 1 to 2, 1 to 4, 1 to 6?
I think it's 1 to 4, I think, yeah. Yeah,
because here in Thailand, people scare using radius 1-to-1.
yeah.
So not many people using 1-to-1. I use 1-to-1, but not many people using 1-to-1. But they like to do like 1-to-3.
Yeah, but you need to understand that the product goes somewhere with 1 to 3 and plus. It's not staying where you put it. But I want to have one more question for you. So how is the timeline? When did the nodules appear?
Around 1.5 months
After the injection?
after an injection.
Okay. So they will all fade again. So I'm sure.
I have a question. When we faced with these silent nodules, will you go ahead treating it or you just leave it?
If they are not visible, I just leave them. They all go away.
I agree with that. So if the patient is bothered by it just because they feel it, I will say, hey, come on, you are not seeing it. Maybe if you see it, maybe we can think about a treatment, but at some point it will disappear with the time,
Okay.
right? And we have to think about also when these problems happens, it's not only a possible trigger that happens around the course, you know, maybe an infection, a vaccine, but also the procedural factors from injecting this product. So how are we preparing it? How clean are we working? And this is something that we really need to emphasize on because we need to be as clean as possible in order to bring this implant that you cannot dissolve as clean as possible into the tissue.
Yeah, so I think it's a matter of before the injection already.
Yes.
Your reconstitution or how you do the dilution. Because when I'm teaching about these products in dilution, I always say the nurse is my enemy. Because the nurse who prepares in advance gives you a dilution which has been sitting there for 2 or 3 minutes, and then it's not in a safe dilution, homogeneous dilution anymore. It's separated already. So the nurse is only allowed to give you the product, and it's very hard if you do it yourself and you have nobody to help you, to give you the product in a homogeneous dilution. And then, especially in the areas where you have a very thin layer until the bone, you tend to have unhomogeneous distribution of the product. And then you might have these silent nodules. And I see them especially where you do your insertion point, because your cannula leaves a tunnel. And in this tunnel, the product gathers. If you have a high dilution, even more, it flows down. And then you can have where this introduction point is, have the little nodule. So when I stop my injection, first thing, I try not to have the lowest point for my injection entry point, because otherwise you gather the product there. And when I stop my injection there, I will squeeze out material, so I'm sure at the entry point I have not a lot of kaha.
Yeah, that's a good tip. That's a good tip.
I wanted to ask one thing that, suppose it was visible. Would that be your first line of treatment, to excise it?
No.
Then what would you do?
No, for sure not.
Okay.
So I'm using triamcinolone, and sometimes
Which
even
concentration?
yes, less
Which?
is more in the beginning. So
okay. 10.
10 is enough, I think, in most cases. And then if it really is a bigger nodule, because sometimes I get complications where it's far too much in one space, and so then I'm sometimes using 5FU, similar as a keloid treatment.
Okay.
I first have a look if is this inflammatory? Does the patient have redness, swelling? Is this big, or is it just a kind of nodule where you don't have clinical signs? Based on that, I do ultrasound, of course. I see if there is a lot of vascularization, and then I try to see where is this nodule located. There is a strong correlation of these problems being located in the fascia and not in the subcutaneous tissue. Then I like to work with steroids oral. If it's a very inflammatory nodule, I like to delineate those before I dissolve or treat ultrasound guided. So I give the patient systemic prednisone in a topper system and doxycycline 100 milligram per day, and at least I do this for 1 month if there is an big inflammatory nodule again.
1 month.
And after that,
One month steroid.
1 month, yes, but in a toppering system, starting
okay.
high dosage, and
How
then I
high?
reduce it. I start with 50 milligram
50
per day for the first week, and then I reduce it then 25, then 12 and a half, then 4.5 or something like that. And then at the end, they just stay with 5 milligrams per day. And when they finish that, I do the reassessment, and you will see that the nodules become more delineated, smaller, and with that, the ultrasound guided injection is going to be easier, and you're going to harm less tissue around. And then I work also with triamcinolone, also sometimes 5-FU if needed as an antifibrotic agent. It's complicated. We don't have really clear guidelines for this. But
Okay. Speaking of this, I have one question that I really wonder, because this is like injectable era, right? We have like all skin booster, and the problem is, I have quite a number of patients that come with a lot of nodules on the face. Will you treat them because they've been treated with all kinds of injectables, Sculptra, Radius, Guri, all kinds, even HA, and a lot of nodules on the face. When you palpate, you can't feel the normal skin. So will you treat that patient to kind of, treat the nodule to go away, or you just leave it? What will you do?
So first you educate your patient that they should not mix in their faces. I mean, this is a really big problem. They should know which product they have in the face, and they should not add biostimulator on top of each other.
That's not my patient.
No, I know. But I think that's very important also for everyone here. You shouldn't mix in a patient. It's really a danger zone. And
These are the nightmare patients, definitely, because mostly they're in the age around 50, 60, so they have atrophic skin. Under it, you see and feel it's hard. So if you dissolve it, the whole face collapses. So it's a nightmare. It's a really, I wouldn't touch them, because if you dissolve it, of course, if they have problems with it, you have to do something. But if they don't complain, the only thing you can do is not to do anything. Because they almost come to your office and I want to add some more.
I already touched them. So
so
I already
a nightmare. Don't touch them.
but I already
don't
did.
touch them.
Yes, I also would reject any treatment and really avoid this mixing up of different products, different inflammatory pathways, and so on, because this is actually the real problem. And people blame it so much to products when they have a complication. It can be the mixing, but it's also how you inject this product in the tissue.
Okay, I share what I did. I did HIFU, the high incidence, focus ultrasound. Patients get better, the nodules kind of soften, but also the face of the patient are sad. Of course. Now it's my next problem. Okay.
So how happy we were with only HA, huh?
So the patients, it's come to the point that the patient asked me, can we stop treating the nodule? Just let it go. Because now they have to face with their,
So
sad face.
non-inflammatory nodule, I would really like to let it slow down itself. It always goes. I mean, CAHA I've seen reducing over 2 or 3 years. But if you just touch it, many of them go away within 9 months. So just don't touch it.
Okay.
Because if you start injecting around with steroids,
No,
if you don't
I
see
don't
that,
inject. I don't
then
inject.
you will have indentations, atrophy, then the patient is even more unhappy, because then they have a defect, and then you will have to treat that defect on top of that. So
Speaking of that, I have one patient who apparently becomes a doctor. So she injects herself with some products, which she shouldn't inject, but she actually did. And then she had like multiple nodules on the face, but she didn't treat herself with injection. She's using all the device. But when she came to me, her skin has atrophy in each of the nodule that she has. The nodule still has, but it's smaller, but her skin is get, a little atrophy. I'm kind of, why nodule get atrophy without steroid? No, without.
might this probably be the similar pathway as when you have atrophy after acne, with acne scars?
With the inflammation?
Yes.
Yeah. That's what I thought. Okay, good.
I would like to ask Mauricio, Do you think that ultrasound guided dissolution by mechanical disruption of Karha nodule will help? Do you think that will help?
I truly believe in that, but only the first 2 to 3 weeks. So my patients get the guidance when I'm using Kaha. If you feel within the next 2 to 3 weeks somewhere a little nodule appearing, they come back, and you can always inject saline solution and then you massage it heavily. It's really reducing the nodule. The problem is mostly gone.
Yes, when it's at the beginning. If you have a late problem, it can be very, very challenging to try to even penetrate into that nodule. So when I have these kind of situations, and if it's not an inflammatory nodule, but the patient sees it and you feel it a lot, I use a 25 gauge cannula, needle, in order to penetrate as good as I can, not using like 30 or 29 because those are not stable enough, and really inject into the nodule. I mix with my triamcinolone hyaluronidase as well in order to soften also the tissue and the nodule so that you have a better penetration and effect of the triamcinolone. And with that, you will use less triamcinolone than usual.
Yeah, that's a very good tip. Yeah.
Okay.
I think there's one more question you have to ask your patient, which is if they are using any home devices. You know, many of them use like bzz, RF or whatever at home, which really can activate the biostimulating injectable. So you do something not good to yourself if you do it too early and after the treatment.
Okay. Yes.
So I just have a question for this case. So why we need to make the incisions? It's the case you just present. It's like a little bit big scar for the face. Yeah, who do this, and the reason why you choose this solution?
It's not me.
Because at our hospital, usually we when the patient comes with nodule, and sometimes you question whether it's infection or not, we will always biopsy. Yeah. And we try to choose the smallest one and try to hide the scar, but we always discuss with the patient first, because most of the patient has been treated from many clinics before, and they want final diagnosis from us. So that's one thing that we can offer for them. Yeah.
Can I add something to that? When you use calcium hydroxyl apatite, don't do bolus injections bigger than 0.2. In fact, I recommend maximum 0.1, and then you do the next bolus next to that one, because if you overdo a bolus, then it's when a nodule is going to come, and pressure and so on. And this product, in my experience, I have the best outcomes when I apply this with a cannula and fan it. And I actually use the 1-to-1 dilution. I rarely inject it pure, but in a 1-to-1 dilution. And I actually don't like to do these big bolus. So maximum 0.1, not more than that.
So there's more to come on that, I think, histologically, also what Kaha does really, because there is a publication on burn scars, like regeneration of burn scars with Kaha. Just, you need to know the product and you need to know the right dilution. And I think we are just in the beginning to understand this product correctly.
Yes. Yes.
Okay, so let's move on to another interesting case. This is a 47-year-old female has been injected HA filler on nasolabial folds, cheeks, and tear trough area. And after several weeks after injection, she presented with these symptoms. She unable to adduct her left eye, like this. MRI there show no obvious emboli. Okay, however, there is some small fibrosis on her left medial orbit. Okay. So neuro-ophthalmology concluded that they suspect a possible filler migration resulting in a partial cranial third nerve palsy. Yeah. Do you see these cases?
Interesting. Oh my God.
This is not my case. This is a case report. Yeah.
Yeah, I have a patient who, I think they injected almost 3 mL of filler in the under eye area, and at least 1.5 ml was behind the orbital septum. And that can cause it because to get a third nerve partial palsy is too far-fetched a theory. And neurologists love theories. And most likely it is that you also got some fibrosis in that area. So that is indication of that you had filler behind the orbital septum. And if you inject enough volume, it will go.
I think what I see more often than this one, maybe less exciting, but not very, but commonly see is when we inject HA around the eyes, and then maybe a year later, the patients complain about eyelid hooding, upper eyelid hooding.
But I wonder, so from the setup of the symptom to the surgery, is how long time? Because if you see the case and you do the surgery immediately, I think that it's so like too earlier. I think that I have some case, one case similar, that the patient come with ptosis of the eye, that's not for the vision, but we just start with the treatment like prednisone and for edema, and after 1 month the result resolved without any surgery. So I don't think that's the indication of surgery for this case. We need to rethinking about this. They do for the oculoplastic surgeon to treat for the trabemus. So it's a little bit.
It's a case report.
Yeah.
I won't do it.
How do
actually,
you?
My patients that I was consulted and I was treated is actually the upper eye area. That is more like a lateral hooding after the patient was injected on the temple, and the anterior temple, and then maybe like a year after, they starting to see that the lateral hooding, one side is more than another side. But if you look really closely, it's look like it's not normal skin. So I, try inject a little bit of the Hylas, and it's gone. So I think maybe this one is another finding that we have to be aware that it can be happen.
What's the one up, one over technique?
I have no idea. I don't use that one. I don't use that one. You need that, yes. Yeah, so maybe, the audience, can note this one and then be aware that this can happen. And then when the patient complains that they have lateral hooding, it's like they consulted for blepharoplasty, but when you really look into it, it's not a laxity of the skin. It's actually the filler migration.
So I think in this case, we should go back to consider about the area that we inject. The most important area is periorbital area because the possible cause of the orbit may be from the injection periorbital area.
If there's any chance that you can also mention about mala edema. I think mala edema is also another, in Thailand, I think it's a pretty common mala edema. So it's from filler injections. So maybe, with the correct anatomy, how to inject, you can prevent this condition for patients because it's very difficult to treat after you already, have edema.
So as you know, either teardrop and the nasolabial area correlated closely to the eye area. So as you know, maybe at the teardrop area is like the limited area because it have the ligament as a boundary. It have the teardrop ligament in the upper boundary. It have the zygomatic cutaneous retaining ligament as the lower boundary. So in the lining layer, as you know, especially near the soup area, you can see like the skin, the subcutaneous fat layer. We have the orbicularis oculi muscle layer. So under the orbicularis oculi muscle, we have the soup. It's like the suborbicularis oculi fat. And below the fat, we also have some septum, in septum that we call like the mala septum. is and under the malar septum, we also have the premaxillary space. So, as you know, at the medial border of the teardrop or the nasogenital groove, we have the one of the most important vein that's lining along with the groove or nasogenital groove here under the muscle that we have the angular vein. So, the soft tissue lining at the lateral face is quite complicated when compared to the medial to the under eye area. So here, but in that case, the migration case, the possibility of the filler that migrate into the orbit may be caused from intraorbital injection. The first is you can, when you do an injection at the under eye, sometimes you can easily to penetrate the orbital septum or the ligament, and then your cannula can insert into the orbit. So this is the one, the possible cause that you can penetrate the orbital septum, especially in the patient who have the aging process of the soft tissue. So one another thing that may be considered in this case, she also inject at the nasolabial fold. So one of the pathway that you can injection into the by the technique, Dr. Ajima, that be concerned about the infraorbital foramen injection. So in this case, maybe it have the accidentally injection along with the infraorbital foramen, and then it can insert into the inferior part of the orbit. Is what happened. The filler can located at the area inferior part that correlated with the oculomotor nerve area that supply the muscle here. This is, you can see that the filler can stay in this area. So this is the one possible cause in this case. So, but by the technique, sometimes the migration can come from the massage. Do you agree with the publication that sometimes the massage can make it a
What do you think?
migration
What do you
filler?
think is a possible causes
Yeah.
of the migration, in your opinion?
I think it's mostly about the technique. So the injection in the fat breast, orbital fat breast, and with the massage, it can move. The filler is like foreign the body. So it's the same like before. It's a lot of people, a lot of women sitting on the needle on the butt. But after you see this, the needle on the uterus or on somewhere in the part of your body, because it has a system every time the muscle contracts and it puts the foreign body to go far away. We see a lot.
But talk to uterus?
No, for the needle, the suture, the skewing kit at home, for the needle to suture your vestment. And then that you sit on the needle, and the ague, the needle comes from everywhere. And it's the reason for the surgical point, when you have a needle in the butt, it's no indication to explore because it goes far away. Or at least you have a need to put everything on the X-ray, on the surgery to find it, because it's very difficult. Yeah, so it moves with the muscle.
I think the smaller the volume you're using, the better you're injecting the tissue, the better is the integration. If you have a bolus injection, of course, and due to the fact of muscle contraction, of course, it can be delivered in another area. So I think the technique is important, also the choice of the filler.
Yes. Please.
I define massage as putting the filler somewhere and trying to take it somewhere else. And yeah, you put it here, then you massage into a new place. So I do not. So that happens when you put it in the wrong place. I never ask my patients to massage. And maximum I do myself is molding. Just tap it so that it blends better. Massage means you put it in the wrong place. So
we need to change the wording here, because this is actually not migration, because the filler doesn't walk from here and ends up there. It's spread, it's redistribution. And this is not really dependent on our technique. It kind of is, but we have to know that we have pathways and connections between the anatomical units in the face. We have connections from the upper face to the mid face, through the temples, through the temporal tunnel, and we have to be aware of that. For example, when you put your filler in the deep piriform space, that space extends up to the medial canthus below the LLSIA muscle. Your filler is going to end up immediately there. The same when you inject the lateral cheeks. The filler, when you inject deep on the fat there, and we just published this, or is in the process of publication, is going to end up in the caudal temple, is going to end up at the preauricular zone, deep on the fat at the parotid, and that happens right away. It doesn't happen 3 years or 2 weeks after that. It happens directly after the injection. Of course, if you just put 0.1, it will have less redistribution than if you use much more material. Also, the rheology of the material, and this was published by Leonie just a few weeks ago, depending on the rheology, it will have a different kind of behavior in the tissue. And we have in the tissue the retinacula, the deep retinacula, the superficial retinacula, and those are the structures that will guide the filler towards another anatomical unit of the face. That's actually the science of this filler behavior and how filler moves in the tissue.
So, yeah, I think it's very important how the tissue move in the tissue. So, because we are discussing about, all we talk about is rheology, but we don't talk about how the fillers actually adapt, to the tissue. I think it's very.
It
I think
spreads.
it's very important.
Spread, diffusion, and toxin. We have to be very clear and precise.
Yes.
But I think it's the mimic muscles who do this spread after the injection. And if you add massage, I'm completely with you. You're doing everything wrong because even if you did a good injection, it might be spoiled after that. So I think no massage and know your product again. I'm so much into. Don't mix around with products. Have one family you like to use and then use this for the next years. Because then you don't tend to change within patients' faces and you know how they behave, how much they will migrate or however, it's not migration, it's spread. We know much more about the products now and the companies do quite a good of science on it. So
Yes.
I think it's important you go with one product line and stay with it so you know how your product is behaving.
Yeah, I agree with you. I agree with you. Yes.
So in case of we don't mix the product, but we inject in a different layer, what do you think? At the same session, such as you use injection from the biostimulator in the superficial, and we use the hyaluronic acid in the deep layer, because we would like to correct every layer aging process.
If you inject HA in a deeper level on the bone or just in the super deep fat layer, and on top of it in the superficial fatty layer, a biostimulator, I don't see actually a problem. But I very much agree with Sonia's statement that if you mix, so if you have a patient and you start to treat him with PLLA, stay with the PLLA. Don't start putting PCL and then something new comes and you CAHA, and that's when the problem will happen. So keep that family together and try to really educate your patient about that.
Okay. I like that. I like that. Okay.
Okay. Another interesting case is 30-year-old woman. She complained about retrusion of her mentum. She had done filler injection, multiple injections on her shin. You can see that from the clinical picture of this case report. You can see her shin is like retracted behind, and you can see it from the bone here. And looking into the bone, look closely, you can see there is a resorption, erosion, and also a bilateral mandibular ramus and mandibular head resorption as well. Do you see this quite often in your practice? Bone resorption issue?
Never experienced that before, to be
Never?
honest.
But you do a lot of ultrasounds.
Yes.
Never X-ray.
Never?
But bone resorption, I don't know if you can really assess that with an ultrasound. You have for that better imaging tools like CT or...
I think there was a study of patients undergoing, I think almost 100 patients undergoing 1 ml of filler in the deep fat compartment of the chin. And a very high percentage showed resorption of bone. And that is if you inject most of your volume in the deep compartment. And that is one thing which will cause, because it is pressure, sustained pressure which will cause. So you have a very high G prime filler and is a deep fat compartment. Volume is very little. And all of them were injected with 1 ml and most of them showed resorption at 1 year.
But I would love to share something with you. And of course, I'm bringing ultrasound again here. When you inject deep on the chin with a needle, you can observe that the filler first fills up the deep chin fat, that little pillow that is whitish on top of the bone. And then the filler is guided into the superficial areas of the chin through the oblique orientated retinacula. So when you inject deep, the filler is spreading and redistributing also into the superficial areas of the chin. So at this point, I really don't know if that much pressure, of course, if you do 3 ml or 1 ml bolus, which I sometimes see people doing this, that can be possible, but the filler is not going to stay there when you inject it.
I think that's why when there's a case report or people talking about bone resorption, it's always there. It's always this location, because that's the location that we actually use large amount of product into that area. Because I'm going to say something, but because I know that your technique, Sonia, your technique is different. So injecting micro bolus and create the chin beautifully, but you do with needle. Yeah, but that is actually will be able to prevent this.
Yes.
Of course, yes.
I think the big bolus at one spot is wrong.
Yes.
Any time, everywhere you inject.
Right.
Yeah, because we've seen with chin implants, they are subperiosteal, there is pressure. You almost always, long term, you see some amount of bone resorption.
Yes.
And the same effect if you create with a big bolus in the deep fat compartment, it logically should cause some amount of erosion.
Right. Yes?
Yeah, I agree with you. It's, for surgeries, we see a lot of chin implant with silicone implant. But since a long time, we know that the adverse effects of the implant, even the silicone or MedPore or OmniPore, everything, is makes the bone absorption later. But so I think that also for filler, if you put deep in the bone and near the bone, you can have the periostin is detached of the bone, so it makes the bone absorption, because the periostin it makes a new bone, and then you separate the periostin between the bone and the filler and periostin, and it's very harmful for with the high pressure, it's very harmful for your bone.
Well, what I find interesting is that we only have it in the chin.
Yeah.
We put
Yes,
the fillers in the zygoma, we put it on the nose.
Yeah.
We never ever see it there. Is there an
Space
explanation
tight.
why it is on the chin?
Or in the
Tight
temple.
space, maybe?
No, in the chin, if you see pressures,
Pressure,
if you see the shearing force is maximum in the chin.
Ah,
Yeah.
Yeah,
right.
the
It is
mentalis
much
is
less in
super
the other
strong.
areas.
Yeah.
The muscle is super strong. So I would really want to guide you technique-wise again. I think also chin, for different reasons, should be built up within 2 to 3 sessions. Because
Yes.
when you inject a big bolus or you want to do a lot in one session, you have a super pressure on the bone. Why? Just let it develop. Let it really, first neurotoxin, second maybe 1 ml but in different microbolus technique, third maybe you do another ml, but then the skin is looser already and you don't have this pressure, so the mentalis muscle relaxes, and then you can fade it out with another
I want
ml.
all of you to note this. This is so true, the technique that Sonia just mentioned. I think it's the most beautiful outcome that you can get from chin injection. Not just, inject with the big volume on the chin. This is totally, I think that one will ruin your anatomy. But the one that Sonia's mentioned about the chin injection, this is just, perfect technique to making a new chin contour beautifully. Yes.
Can I challenge you with one question?
Myself?
So no, all of you.
Oh, you okay?
So
good.
if you have this problem with filler on the
Okay.
chin, how can you explain that you have this similar problem with ends up with bone resorption after injection of toxin on the masseter? That you have mandibular bone resorption as well, because I've seen published cases
Yeah.
about this.
So fibroblast activity and also probably osteoblast activity is induced by pressure or stretch. And probably then there's less stretch to the osteoblast and less pressure. So you have, especially stretch, you will have no bone needed there, let's call it this way. I think this is my only explanation, because these cells communicate and then they need their attachment to this muscle.
I'm with her. No, I'm with her because
Sounds logical.
Yeah, it's true because like when you take out your tooth, in that particular area you actually have because you have less muscle movement, so you have more bone resorption, particularly on the area, at the area that you lose the alveolar bone.
And the reverse is true. If you have
Yes.
more hypertrophic muscle, you will have more bone
Yes.
hardening at that area.
Right. See, all the physiology.
So it's about stretch and pressure. No?
Yeah. It's about muscle exercise. That's why energy-based device of that one, with the what do you call this, the ETS, electrical stimulation, is working. Yes.
Okay, so right now we are going to move to the last part of our session, the female genitalia complication. I think you have seen lots of fatal cases after labia or vagina injection. So today we're going to share you some cases. The first case is a 45-year-old Asian woman. She received filler injection of unknown composition into labia majora. And a couple months after, she started to palpate a mass with intermittent pain on her labia. And the mass gradually increased in size and started to get swollen and got inflamed. Physical examination show swelling and redness around the labia majora. The doctor suspect soft tissue filler injection with cellulitis, and IV antibiotics was given. The patient followed up for the next couple of days and started to develop fever and dyspnea and require hospitalization. And her vital sign BP is decreased, and tachycardia, and got fever, and chest X-ray showed pulmonary edema, MRI showed myositis on the muscle, and the diagnosis was changed to sepsis secondary to cellulitis and myositis. And the culture of the wound showed up to be Corynebacterium striatum, and IV antibiotics was given. You can see that the infection progressed to necrotizing fasciitis, and so she required fasciotomy eventually. And you can see that this is the tissue of the labia that got excised from her. You can see lots of material inside the tissue. This is the reconstruction after the treatment. You can see quite devastating, and there's a lot of flap done. And so the diagnosis of this case is suspected biofilm and lots of infection, cellulitis, necrotizing fasciitis, and the material is actually unknown composition. So what do you think about this case?
Do you guys doing injection at the intimate area? No? Nobody? Do you do? You do fat?
Fat.
Okay. So, comment.
Oh yeah. So for this case, I think they are like quite common in terms of the infection. However, for this quite rare case that is very late, it's like a year after the first injection, and it's happened. Mostly, if it's pretty much like you already discussed on the first case that you have infection mostly right after injection. And for this case, they are like very late. And I think there is maybe some other causes. For example, her underlying disease. So we have to explore like what that contribute to her condition right now. And another thing is, so the bacteria that she got infected is quite virulent. So she have developed necrotizing fasciitis later on, and it's like kind of life-threatening condition. So, so for most of the fillers, mostly is resolved after a year, right? For this case, it's very rare that it's like happen after a year. So if I see this kind of patient, I may have to explore like other causes.
Was any STD diagnosed? Or-
Not mentioned in the paper. So
No comments.
in terms of OBGYN aspect, infection around this area, what are the major points that we need to concern? And do the patient need to seek treatment sooner than this, or?
So for this genital area, the infection may happen if the patient have.
How often? How often? Is it common?
So far, the filler injection is not
For-
common
okay.
at all. Yeah, but in terms of like genitalia infection, like if the patient have the STI, or if the patient, STD, or if the patient have like underlying disease that's distributed to her immunocompromised, for example, it maybe can cause that. Or even if she have like some pathology inside the area, like for example, the benign or malignant lesion, that's maybe contribute to that. However, for this case, it's quite rare. It's maybe from foreign body itself that like later on become like a source of infection.
I have still questions. Was it a single only injection? Are you sure?
She
I
had
never
done
trust my patients
multiple
there.
injections.
Multiple injections.
Yeah,
So
but
maybe
only developed symptom after the most recent one. Yeah,
okay.
but she had done
Always
like
the most
multiple.
recent one is
Yeah.
the one to blame. But
Yeah.
you know, again, mixing products in one area is a difficult task, even with HA. And I truly believe that we stress our immune system tremendously because HA is different and it's not gone in 1 year always. We have many HAs who can stay much longer. So I think beside an infection from outside, it's also an immune reaction to the products which might be mixed in the place injected. And then the story goes on. I think it's maybe this is part of the problem.
Yes.
Is it normally when you do injectable in the genitalia, do you have any like special precaution that you normally do to prevent the complication, or basically it's not common because of high vascularity?
So for the external genitalia,
Yes.
like you mentioned, I would agree with you that most of the delay complication cases may happen, especially granuloma. So after injection, is beautifully, but like after a year, the patient come back with like a new developed lump. So I think it's quite common in terms of probably like contribute to the immune response from like the injectable product. And another one, you may have to consider whether the providers that inject, this is legal or not. Because we see in many cases that the patient receive injection from like illegal provider. Yeah, and another one is the product. Yeah, I have many cases that came here after like 5 to 10 years after got injection, and she developed like the huge granuloma, or even like kind of have the ball at her genitalia. Yeah, so it's quite devastating. But I think for the external genitalia, it's quite safe to do if with the trained providers and the safe product that like pass the FDA. So the possible like vascular complication is not mostly not from the external genital injection.
From inside.
So in this case, we find that the battery is Corynebacterium trium. Is in fact that this battery is on the skin. Is not supposed to make the infection so severe. That in case very special, because in almost of you have this kind of bacteria. So why it can make the infection? So I wonder that perhaps the patient also have the favorite factor to get infection easily. But the most important that in the genital external organ is considered that is a lot of bacteria. So what kind of the you use betadine, you use hexachloroquine to clean before you do the I use mostly betadine. I find that it's safer than I don't know how the chlorhexidine, but for the external genital it's prefer for use betadine. And also do you think that we need for all kind of injection the patient need to have antibiotic prevention like intravenous or even oral before you do this because to prevent this kind of infection? What do you think?
For me, I still refuse to inject these areas. First, because there is a lot of mechanical activities that might happen. The bacterial or the microbiology burden in that areas is so different than in the temple or on the cheeks. And you never know what and how is the lifestyle of the patient that you inject there. So even if you have the cleanest injection and the best product, if your patient doesn't care, then that's something going to happen. Then you have, I would never, for example, also dare to inject a penis. This changes at least 4 times per day its size, right? So how can you imagine that a product will spread in an even manner in the penis? And so that's why, in my own experience,
I'm trying to imagine. You know?
oh, no. This is why I still really have a resistance injecting these areas with fillers.
Yeah, I want to comment on the bacteria part. As I'm still doing labiaplasty surgically, so labia minoroplasty. And I think this is and you never get this really sterile when you perform the surgery. It's not possible because of the bacteria of the vaginal flora. So I think, and amazingly enough, this is a surgery which I've never seen an infection there. So somehow the body, and also after giving birth, you know, in this area there are many stitches done and everything. And it's very easy to heal, usually. It's very easy to heal. So it must be something in combination between product and unlucky
I think it's
circumstances,
microbiome.
disease.
Yes. So around that area,
Microbiome,
because inside vagina we have like very good microbiome system, and I think it's kind of protective effect. And I would like to emphasize that in terms of prevent infection, first, if you would like to inject at the external genitalia, avoid shaving 3 days before you inject. All right. The second thing, when you apply antiseptic, apply at least 3 times, okay, to prevent like the possible of the bacterial infection. Yeah.
See, 2 things I want to say. One is there were air bubbles inside. Whether they considered anaerobic infection and treated that or not, because normally you don't get air bubbles in any other infection. And secondly, there is huge venous sinuses in the labia minora. So if there is infection, it is very easy to enter the bloodstream. So the incidence of sepsis, patient went into septicemia, that is likely.
Okay, good to know.
Okay, the next case is 38-year-old female. She admitted to emergency department due to loss of consciousness. Okay, after she had done a filler injection into the vaginal wall, Okay, and over 7 months, she had done 47 mil of HA into the vaginal wall. And the last injection was 48 days ago. And today, she inject another 15 mil of HA into the vagina. And today, she collapsed. Okay.
Oh my God.
And at emergency department, she's quite unstable. And initially, she was diagnosed with anaphylactic shock, since her symptom looks like it, and has been treated as anaphylaxis. But eventually, they started to suspect something else that eventually showed up to be pulmonary embolism because of EKG as well. And other work also pointed to pulmonary embolism. And she later started to have multi-organ failure and die eventually. What do you think about this case?
Oh yeah. So basically, this case have the pulmonary embolism after the filler injection, and you can notice that she have like multiple injection, and the amount is more than normal, beyond like normal amount that we normally inject. And yeah, so like if you know from anatomy, there's a lot of blood supplies around vagina.
Can you explain a little bit how you actually inject the labia?
So, this case, I think she inject inside vagina, which for improve her orgasmic disorder, mostly for enhance like the G-spot area. Yeah. So, and another one is for
we
like
put
for treatment.
47 cc inside? Can we put 47?
I think it's too much.
But I mean, anatomically, can we put 47 cc?
So normally, if I normally not inject the HA inside vagina, but I inject PRP. But for the like G-spot enhancement, normally just like 4 to 5 cc max. So I think this 47 maybe around vaginal wall, and I'm not sure whether she like treating for her vaginal relaxity or not. Yeah, because if she have vaginal laxity, it may have to use a lot of amount. Yeah, but if I see like she have vaginal laxity, I would prefer energy-based devices or even surgery like vaginoplasty. Yeah, so no point to inject a lot of amount of the HA.
Yes.
Yeah, and as you know that inside vagina is the closed space, and the pressure inside vagina is very high, right? It's like when you do Kegel exercise. Yeah, the pressure inside is a lot, and the blood supply around vaginal area, is very good. That's why the healing is good, right? Yeah, and she have like huge amount of the filler. It's not. I think it's increased every risk as possible that she going to have the embolism.
It's too bad.
I mean,
So I think it's rare, very rare. Yeah, because it's too much. Yeah.
What is normal amount for vaginal injection?
So like I said, if for the G-spot augmentation, around 4 to 5 cc. Yeah,
I mean, 47. She must be very rich.
exactly.
You know, to get 47 cc.
Well, body filler are cheaper.
And we also concerned about this complication because our institute have the aesthetic regenerative gynecology fellowship training. So we have the hotline just in case if the patient receive the filler and have like the complication like this, like vascular complication, the providers can call the hotline number and refer case to us.
You get
So,
one now? Do you get one now?
So
you
I
get
can.
many?
So
How many you get? I'm
not
curious.
never yet. So but we have the hotline just in case if like something happened.
Okay.
And it's like after a couple months, I think it's like the like big news for the patient that had died from filler injection inside vagina. So
Yes, the big one.
it's
yes.
it's
Big
kind of
news.
like right now most of the doctor kind of cautious about how the amount of the injection.
Okay.
Yeah.
Good.
Yeah, and this case, autopsy was done, and you can see gross embolization of filler into paravaginal vessels. That the arrow pointing, lots of it. And microscopically, you can see basophilic staining material and hemorrhage in vaginal and rectal walls as well. And stain positive for Austrian blue. Austrian blue is the stain for HA filler. You can see the bluish material inside the vessel wall. And autopsy on the lung, you can see congested and hemorrhagic lung and diffuse alveolar hemorrhage, and also the same material inside the lungs. Scary.
It is so interesting. Can you talk about the danger zones in the vagina? So where is it less risky and where is high risk to inject around the vagina?
I think inside vagina, the location, right? You mean the location
Yes,
where
the
it's like
location.
the safe area? Mostly not safe. Yeah, because have you ever heard of amniotic embolism? So during the delivery, yeah. So that not even like have any foreign body is like the amniotic fluid that when the uterine contraction and not even have any injury, the patient can have the like amniotic fluid embolism. So we don't know the cause yet, and it may contribute to like the contraction of the uterus and the blood vessel around that area. And I think for inside vagina, the vascular everywhere. So maybe Dr. Song will show you the picture. Like, so I think it's not safe to inject inside vagina.
And
Yeah.
the pathway goes through the iliac vessels, through the liver, through the heart, through the lungs.
Yeah, so it's like
Okay,
two
yeah,
vessels that can go through. The first one is like the vaginal vessel, and another one is uterine vessel. So it can go through that and then throw emboli up.
Did this have had some legal consequences for the practitioner, or was like, oh, happens?
I think it's not mentioned in the paper. It's a paper case. Yeah.
All right. Now
So-
she has an answer for you.
Yeah, so what is the highest risk of our filler or G-spot injection? Like I said before, the external genitalia is very low risk. So if you want to inject, external genitalia is quite safe, okay? However, if you want to inject inside vagina, you have to think twice, whether it's necessarily or not, or do you have like any alternative treatment? Yeah, so you have to tell the patient like what is like the options for her and what is the risk if you inject the filler inside vagina, okay? And the most dangerous is like the previous case, is like vascular complications. And so I think the complications may happen in terms of the location of the injection, the experience of the injector, and the patient expectation. Because when we inject, if we inject like inside vagina, and the amount is not that much, it may not correct the anatomical relaxation. So you may have to like counsel the patient. Okay, and for the complications, yes. So if the patient have the severe pain or have systemic symptoms like dyspnea or like chest pain or hemodynamic change, patient want to faint, you have to be careful. You have to like activate the emergency call.
Yes, doctor. Hello. So you mentioned about injecting PRP, 4 to 5 ml in the G-spot area. Is there anything that we have to watch out for, like another possible pulmonary embolism with PRP as well?
So for the PRP injection, because it's quite safe, it's the patient's blood, it's autologous, and the complication that may happen if it's thrown into her blood vessel is not the foreign body. Okay, so it's less likely to cause any like serious complication. Yeah, and so we never seen the case report about the PRP injection that caused the like vascular
We do on the face.
complications.
Oh,
You do.
there are.
There are, yeah.
We
Okay.
know Chinese from PRP blindness.
Inside vagina.
Yeah, the blind.
No, not from the vagina,
Okay.
but from
Blind.
Yeah, I
facial
mean from-
injections,
from the
from
vagina.
glabellar injections with PRP causing blindness.
Yes. Okay.
So-
Who knows?
Yeah, so
be
the
careful.
previous one is a paper.
Be
that-
careful.
Okay. Yeah, so we don't see the case report that inject the PRP inside vagina. Yeah.
Yes.
So when I see all those complications, better not to inject the G part. It's better to change the partner.
Yeah. Thomas.
Yeah, so from the list of the complications that may happen, it's mostly from vaginal injection. So for the external genitalia, it's less a risk.
I'm okay.
So for long-term consequence, it may happen like the first case that you have like infection, or some have like granulomatous, have like chronic pain, or even necrosis like scarring. And another one is the psychological consequences that can happen. This is a granulomatous that she had like injection like 10 years before she seeing me. This from illegal injector, right? And the product that used is not medical grade. Okay. And after like removal is like the last picture. Okay. So yeah, like I said, the location of the injection, the technique, and the counseling is very crucial.
Okay, so
I think we
for
ran out of
the
time.
final, the final we will talk about some anatomy about the external genitalia and the vagina, just in recap. Normally, when you
5 minutes.
injection in the labia majora, we have so many layers. The first is skin, and under the skin we have some condensed of the smooth muscle and the fascia that we call dartos fascia. So the target of injection is under the dartos fascia. Is correct, right, Dr. Oravi? So why this area? Because this is we remove the dartos fascia, and you can see the pocket of the fat under the dartos that we call like the fibrous tunic sac here. So the target for injection is to be between dartos and the fibrous tunic sac here. So why? Because in this area is like the non-vascular area here is quite safe when you do injection in this layer. So if you inject too deep, you can see that we have some vascular or the artery that supply underneath the fibrous tunic sac here. But this is the external genitalia. And what about the vagina? So normally the vagina, you can see here, we have the layer, the mucosa layer, and we can see in the lamina propria layer, you can see the lumen of the vessel. It have a lot of the venous plexus under the epidermis layer here. This is the reason why when you do injection in the vagina, easily the filler, it's easily to get into the venous and then go back to along with the venous system, along with the uterine vein, and then go back to the internal iliac vein, and then go to the inferior vena cava, and then go to the heart. And after that, it can move into the lung, and then finally we can get like the pulmonary emboli. So this anatomy show you about the vascular plexus at the wall of the vagina. So please aware when you do injection, you shouldn't inject the HA in the vagina. First of all. Okay, I think that's all about the genitalia.
We are at the final, at the time already. We ran out of time. Thank you so much, everybody, to stay at the end of the session. Thank you, our
Thank you.
panelists. It's so fun.
So inspirational.
Yeah, right. We do again next year. Okay. Okay. Yes. Already. Thank you so much. Thank you, everyone.
Thank you so much, everyone.
Picture, please.